There we go. Excellent. So, hello, and today we're going to talk about new tools and new insights into diastolic dysfunction. And if we start from the end, the take-home message today, I'm going to talk to you about a concept that you may or may not have encountered before, and that's hydraulic forces. And hydraulic forces contribute to diastolic function and can be assessed by echo, and we'll talk about how that can be done and why that's important. Secondly, myocardial stiffness and damping, also words that we maybe not always use and maybe aren't particular about and specific about what they mean. These are mechanisms of diastolic function that can be measured by something called the parameterized diastolic filling method. We'll talk about that. And I acknowledge, Greg spoke earlier, the mechanisms. Nobody cares about the mechanisms, says Professor Scalia. Well, there are interests in those mechanisms. First of all, we also like to understand what's happening in our patients and the physiology. But importantly, insight into those mechanisms helps us realize that not all diastolic dysfunction was made the same. So not all diastolic dysfunction manifests in the same way. And we'll talk about that as well. So beginning with hydraulic forces, a hydraulic force from physics is the force exuded on a surface by a liquid and the pressure in that liquid. And it's simply calculated on the left here. Hydraulic force in newtons is the pressure in the liquid multiplied by the area that it is exerted over. And by schematic in the middle, we can see here that in a schematic left atrium and left ventricle, the hydraulic force is directed orthogonally towards the wall of the chamber. And in a curved chamber, that will be, at different angles wherever we are. However, they can be split into a longitudinal component and a radial component. And let's just focus on the longitudinal component of the hydraulic force. So if you have a left atrium and a left ventricle with an open mitral valve and the same pressure in the atrium and ventricle, there will be a force directed towards the apex in this part of the left atrium, and there will be a force directed towards the atrium in this part of the left ventricle, opposing each other. And if we make it even simpler here on the right, with the top being the left atrium, the bottom being the left ventricle, and an open mitral valve schematically illustrated as a piston that can move back and forth, if there's more area on the ventricular side, if there's more area on the ventricular side, as illustrated by these red arrows, there will be, despite having equal pressure in both chambers, a net force driving the AV plane back towards the direction of the atrium. And that's a little bit, that first time I encountered this, I was forced to think a little bit about it. So even though the pressure is the same, because of the geometry, if the ventricle is bigger, there'll be a net force driving towards the atrium. Conversely, if we have a small ventricle and a large atrium, there'll be a net force opposing the return of the atrial ventricular valve plane towards the atrium. So the geometry, or the relative geometries of the left atrium and the left ventricle to each other, their relative sizes, has consequences for what's happening and what's aiding in the filling in the terms of forces. So we studied that in healthy individuals with magnetic resonance imaging, and we were able to very accurately measure the areas of the ventricular short axis area and the atrial short axis area. Let's just focus on the bottom here, the ventricular short axis area and the endocardial surface. And you'll see that during systole, obviously the ventricular short axis area becomes smaller due to the contraction of the left ventricle. But if we just look at focusing on diastole, during the early parts of filling, the ventricular short axis area is smaller than the atrium. Sorry about that. But during the majority of filling, we have a ventricular short axis area that is larger than the atrial short axis area. That means that the ventricular, the geometry of the ventricle is helping the filling and the return of the atrioventricular valve plane by this hydraulic force. Is this important, and does this differentiate between patients? Well, we also studied that recently. Here we have that atrioventricular area difference, the difference in the size of the area of the ventricle, the short axis area of the ventricle compared to the atrium. And on average in healthy individuals is about 20 square centimeters. And then that is reduced in patients with HFpEF and amyloid. And they would have then sort of smaller ventricles in relation to larger atria. Whereas in HFrEF, you can even see the opposite, where you have the large ventricle and the small atrium. So it is possible mechanistically that this can occur. So then we wanted to see, hey, does that have any importance and use for survival? So we went and turned to NEDA, the fantastic resource that we have here in Australia. And we couldn't redo measurements in NEDA because NEDA only has the existing measurement data from clinical measures. But we used the left ventricular end diastolic diameter and the left atrial end systolic diameter as sort of surrogates for this hydraulic force, or surrogates for the relative sizes of the atrial ventricle in order to measure the atrioventricular area difference. And we saw that the atrioventricular area difference indeed had a dose-response relationship to survival, which was on par with that of E over E prime and also a grading, conventional grading of diastolic dysfunction. And in fact, it was significant beyond conventional measures such as E over E prime and diastolic dysfunction measures. So it adds information beyond that which we already have, which indicates that it's providing some complementary diagnostic performance and may be worthy looking at. So if you have the ability to measure the left ventricular end diastolic diameter and the left atrial end systolic diameter, which arguably would be done routinely in most patients, you can get important incremental information on diastolic function through the atrioventricular area difference, or AVAD. Now, pivoting to more challenges that we have with diastology. So we have on the left a slew of measures that we use routinely. Unfortunately, these measures have limited correlations with invasive pressure indices. And if we talk about diastolic dysfunction grading, Greg lauded the simplicity of being able to count 1, 2, 3 or similar things, and that's good, but it is really a sort of a phenomenological approach. We're looking at phenomena, we're counting the presence of things, we're voting, as he would say. But this commonly leads to an indeterminate outcome. And a mechanistic approach would be desirable because we want to understand what's going on and not just be counting or voting. Because arguably, when we understand the physiology underpinning what's going on, we can potentially make decisions about treatment that might be different, which of course would only be relevant if you find different mechanisms. And that's what we're getting at. So let me show you how we can do that. Let's start by talking about the left ventricle in terms of a spring coil. So in the beginning of the cardiac cycle, it is fully expanded. We compress that spring by moving the atrioventricular valve plane towards the apex, in this case in magnetic resonance images, but it's the same physiology in the echocardiogram. And then during diastology, there's recoil of that spring. Well, it turns out that left ventricular recoil during diastole behaves like the physics of a spring. And I was forced to sort of recall or be reintroduced to my high school physics textbook and the damped harmonic oscillator. The damped harmonic oscillator is, I think of it in the terms of a diving board. In the beginning, there's the big oscillations, but then it sort of dampens off and it stops. So, or boing. That is the behavior of a damped harmonic oscillator. And it turns out that the left ventricular filling behaves exactly like that. Boing. And so here we see, for example, by analogy, the displacement in some distance over time that is reduced, and there's a formula for that. Let's just accept that there is a formula for a moment. And it turns out that the E wave can be traced by a function that behaves according to that formula. And when you do trace an E wave using that function, you can extract parameters such as stiffness and damping. And now it gets interesting. So stiffness and damping are two very different parameters, and both can be uniquely gleaned from an E wave, and it tells us about the myocardial properties. And this was described for the first time back in 1987 by Kovacs at WashU in St. Louis, and it hasn't really caught on, mainly because it's been sold in physics terms. It's been written, Kovacs is a dual-trained astrophysicist and cardiologist, and a lot of their work was very physicsy. And I would argue that we need to, if we can take a physiological approach, we might be able to glean some important information from it, and also we need to have simpler methods to do it. Well, it turns out that the complicated methods of tracing the E wave need not be done. It's enough just to measure the acceleration time, deceleration time, and the peak velocity of the E wave. So we set up a website. You can go on your smartphone now or today, echoewaves.org. You can click on the web app, and then you get an interface like this. You enter the acceleration time in milliseconds, the deceleration time in milliseconds, and the peak velocity of the E wave. That's it. And then you can output a slew of measures, including stiffness and damping, also called viscoelasticity. So what other measures and why is this important can we glean out of this if we're going to be able to measure the acceleration time, deceleration time, and peak E wave, and then get these mechanistic characteristics? Well, it turns out we can get stiffness not only in terms of the damped harmonic oscillator, but it correlates extremely nicely with that gleaned by invasive catheterization. On the left-hand side, on the top, we have the E wave and the A wave, and during that simultaneously acquired with high fidelity pressure Millar catheters in the cath lab, and there we get change in volume and pressure over time. So we have the lowest point of pressure, and it's changed up to the point of volume stabilization. So we have change in volume and change in pressure, and that is this catheter-based stiffness, delta P over delta V, change in pressure over change in volume on the horizontal axis. On the vertical axis, we have the E wave stiffness parameter in grams per second squared. And there's an extremely tight relationship. So it's just a linear relationship. Conventionally, we can just calculate the invasive stiffness based on the singular parameter that we can extract from measuring the acceleration time, deceleration time, and E wave peak velocity. Furthermore, Greg also mentioned tau. Measured in milliseconds, it's the time constant of isovolumetric pressure decay, first described by Weiss. Here we have pressure during isovolumetric filling, and you can solve for a time constant expressed in milliseconds. Turns out that a parameter that can be gleaned from the stiffness and damping measures that we can get from the parameterized diastolic filling, just measured from the E wave, correlate extremely closely and nicely with tau, so we can get an estimated tau just by measuring the E wave. So let's talk about what these parameters are and why they might be important. So what is stiffness and what is damping? So let's start with that compressed spring at the end of systole, and then talk about and think about what happens as that spring expands during diastole. So here we have the compressed spring on the left, time during diastole on the horizontal axis, and what's happening then during that time is that stiffness is contributing to the force that's driving the recoil of the spring. And damping is a mechanistic property that's contributing to the forces that are resisting the recoil of the spring. Some might talk about it in the analogy of the door with an automatic door closer. If you set it wrong, well, you open the automatic door, that's the systole, and then diastole, if it doesn't have any damping, it just goes wham, and it shuts. There's nothing stopping it from closing the door. But a properly damped door closer will make it nice and smooth and damp it from hitting hard, and the door closes nice and softly. So the stiffness is what's trying to close it, and the damping is what's stopping that closing. Or by analogy in the heart, the stiffness is driving the filling, and the damping is opposing it. So what does that mean mechanistically? Well, conceptually, and this remains to be proven, and we have work in this space trying to get there, the stiffness is being driven by things like elastin and collagen and titin, and the recoil of the vessels, the great vessels and the surrounding tissue, whereas the damping is being contributed by calcium sequestration and cross-bridge uncoupling. And these are fundamentally different mechanisms, often occurring in unison, but they have some important differences. And let's see how that pans out. Well, it turns out that when we do these kind of measures of the E waves by echo Doppler, to glean these mechanistic properties in, for example, on the left-hand side, in reduced ejection fraction, the patients that have increased that have diastolic dysfunction, here grade 2 or 3, they have increased stiffness as the primary driver of their diastolic dysfunction. By comparison, in patients with normal EF, but that have, for example, hypertension or diabetes, it is the increased damping that is driving their diastolic dysfunction. So let's think about that. When we do our grading in our assessment of diastolic dysfunction, we say, oh, this person has diastolic dysfunction, yes or no. But the diastolic dysfunction are two different things when you go down to the mechanisms. And those mechanisms, although it remains to be proven, have connections, or at least physiological connections, to processes which can be targeted pharmacologically in very different ways, or other kinds of therapies, but primarily pharmacologically. So it may be that the improvements in diastolic dysfunction that we would want to get in the settings of reduced EF and normal EF, or HFpEF, are different. And that is why it's important to have mechanistic insight into our phenomena that we can vote or count on. So I humbly submit, Professor Scalia, wherever you're sitting, that maybe it is interesting to get insight into the mechanisms of the diastolic dysfunction if it has consequences for therapy. Now, we're not there yet. There's a lot of work to be done and to be proven, but that's sort of, if you live in a world where there are only white swans, you don't think there are any black swans, but you see that first black swan, and you're like, oh, not all swans are white, which was a big surprise for me coming from Sweden to Australia to see my first black swan in the lakes of the body of water in Canberra. There was a black swan. I was like, holy cow, a black swan. Well, I'll show you. This is a black swan, if you will, I propose, for diastology. Furthermore, you can intervene upon these parameters. If you have the setting of hypertension and HFpEF, and you intervene with the DASH diet, you can both reduce the damping and the stiffness of the left ventricle. So it's an intervenable and measurable endpoint. We have normal values published that you can take a look at. And so we have an accessible method, normal values. We know we can intervene upon it, and we have the ability to characterize different diseases to see of potential therapeutic benefit. In summary, we've talked about initially hydraulic forces that contribute to diastolic function and can be assessed by echo through the atrioventricular area difference. It's just based on the geometry, the differences between the left atrium and the left ventricle, but there's a connection to the physics in there. And then we have myocardial stiffness and damping that are two opposed mechanisms contributing to filling. The stiffness is driving the filling, and the damping is opposing the filling, when we can measure it simply by measuring acceleration time, deceleration time, and peak velocity of the E wave. And importantly, not all diastolic dysfunction appears to manifest mechanistically in the same way, and it remains to be shown whether or not that has consequences for therapy. And with that, I thank you for your attention.